Good morning, everyone, and thank you very much for joining us today as we look to explore clinical governance, performance and audit as a driver for best practice within continuing healthcare. My name is Seb Stewart. I'm the Service Development Director with CHS Healthcare. CHS Healthcare worked across the NHS for many years, 25 years, delivering a range of services across patient flow, but also around CHC, where we support a number of NHS organisations up and down the country, delivering reviews, assessments and audit as well. And we also have two software platforms, CareTrack and Broadcare, which we provide to around about 75% of CHC services across the country. So delighted to see so many people attending the webinar today. We're expecting up to 120 people from across the country and from a range of different roles which relate to CHC. So I've introduced myself. What I'd like to do now is to introduce the two members of our panel today. Paul, would you like to introduce yourself first?
Yes, thank you, Seb, and good morning, everybody. I'm Paul Kaye. I'm from Quiq Solutions. We provide quality assurance, compliance, data and analytics solutions really across the health and social care spectrum. So we have over 600 care home and dom care customers. We work with NHS trusts, and at an ICB level, we have the chat tool, AIMS. We have other tools that we use with the ICBs, such as special educational needs, safeguarding, and commissioning tools working with providers. So, we've really got quite a comprehensive range of services and experiences working in this sector.
Thank you, Paul. Dan, would you like to introduce yourself?
Yes, thanks very much. Morning, everybody. It's good to be with you. My name's Dan Harbour, and I run an organisation called Beacon. We're a social enterprise. And we deliver information, advice and casework in continuing healthcare across England. And we're also providers of the National Information and Advice Service, which is a service commissioned by NHS England. I've worked personally, I've worked in continuing healthcare advocacy, training and development for almost 20 years. And Beacon tries to use the experience that we gain and the knowledge that we gain at sort of ground level to help support training and development and improvements across the system.
Thank you, Dan. So by way of introduction, I think we all know and appreciate that clinical governance and audit is a critical issue across continuing healthcare at the moment, particularly as the CCGs transition into ICBs. So I hope today that what we're able to do is answer some of the questions that you might have and to provide some useful insights and advice on this particular aspect of CHC. So our aim today is to address a number of particular discussion points. So we're going to be looking at how audit can be easily implemented as part of everyday business. How can compliance be made front and centre for all commissioners? We're going to be looking at how at a national level ICBs are monitored in the context of CHC performance, and also how can qualitative audit tools support the drive for best practice within NHS Continuing Healthcare. There is, of course, also the opportunity for you to ask any questions that you might have to take advantage of Paul and Ben's expertise. So please pop them into the Q&A function. So we'll be watching these, monitoring those and trying to gather those into themes and answer as many as we can during the course of the webinar. So as I said, please feel free to put any thoughts or questions you might have into that. So let's crack on immediately. So Dan, what I'd like to ask you is why is audit important to improve performance within NHS Continuing Healthcare?
Well, look, continuing healthcare is a highly complex subject area, as I'm sure we all know. I remember when giving evidence to the Public Accounts Committee in 2017, Simon Stevens dropped the national framework on the desk with a great thump to demonstrate the sheer volume of policy and guidance and tools that we have to contend with in order to deliver a fair and compliant assessments of care provision. So it's complicated, it's convoluted assessment process, highly complex set of criteria, which can be honestly open to subjectivity, despite all our best intentions. And so it's inevitable that there is going to be variation in its application. So it's crucial for us to stay across performance and decision making at all the key touch points of the patient journey, so that we can pick up on where that variation exists, any compliance issues, and ensure a fair and a consistent approach in all areas of CHC operation. When the National Audit Office investigated continuing healthcare in 2017, they accessed all the national data they could get their hands on, and it was quite telling at the time that their conclusions were quite limited because there was such little data available. Now, things have moved on considerably since then. National reporting requirements in continuing healthcare have improved significantly, and those have been strengthened again this year following consultation by NHS Digital. But we shouldn't just limit that data collection to just those national parameters. We should be aiming for continuous improvement, and we can, if we can do that, in order to do that, we really need robust systems for collecting information across all of those touch points: awareness raising, referral, recruitment and retention, assessment, decision making, care planning, commissioning and procurement. Otherwise, we're not going to know what's going on and we can't make those improvements.
Thanks, Dan. Paul, can I ask you where chat fits into audit and how it's used?
Yes, thank you, Seb. The chat tool, another acronym, Continuing Healthcare Assessment Tool, has been around for a number of years now and is designed as the self-assessment mechanism for previously CCGs, but now for ICBs and their sublocations. It covers three main themes. So you have assessment, decision making, care planning and commissioning, and enablers. So some of those elements that Dan was just talking about are included in the chat tool. And from a user point of view, the idea is that it's a self-assessment by the ICB or their sublocations, and that is then peer reviewed by NHS England, and then systemic issues could potentially become obvious because chat has the ability to compare and contrast the self-assessed performance, the RAG ratings that the users of the system use to identify their strengths and weaknesses can be compared and start to highlight trends. But really, it's a developmental tool, so it has best practice guidance, lots of information in it, so that a user can benchmark their service, their CHC service, against what the best practice guidance would be, and it sort of gives them aspirational goals and objectives to aim at. If they are using the tool correctly, will help them drive continual improvement, and by setting reminders and alerts at appropriate times, it should help that process by making sure that the things you say you're going to do, the action plans you might have in place to improve, actually take place, with lots of reporting, both at a local board level, but also nationally and regionally, as I said.
Thanks, Paul. And how does chat fit into children's continuing healthcare?
Well, we've got some experience with children's continuing care with some CCGs previously using the chat tool for that purpose as well, because of the commonality. However, children's continuing care and adults continuing care are two separate things, legally, I believe, and they have separate frameworks. So it's not directly comparable, but obviously we now have all age continuing care, and a new sort of umbrella term for all sorts of funded care. And I presume, I'm not sort of party to those discussions, but I presume the direction of travel with NHS England will be to put all those things under the one umbrella, and try and consolidate and integrate teams going forwards. So we'll wait and see what impact that has on the chat tool itself, but it could mean that chat becomes, you know, more of a tool to cover some of those other areas, including children's continuing care.
Thank you, Paul. So Dan, at national level, how are ICBs monitored in the context of CHC performance, and what does this mean in practice? And I suppose, you know, what are the implications if they don't monitor performance?
I'm going to, I'll give you my, I don't work within an ICB or NHS England, so I'll give you my external perspective on that. The core methods of monitoring include national statistics reported to NHS England, NHS Digital, for analysis. So previous lines of reporting for quarterly monitoring and monthly monitoring included eligibility rates per 50,000 head of population, split into standard and fast tracks, new referrals, completed assessments, total numbers eligible, conversion rates, and local resolution statistics. Those data we know have been used in the past to identify trends such as eligibility outliers, which are often indicative of performance issues within a CCG. Additional lines of reporting have now been added, as far as I'm aware, for this financial year. So we have a new patient level data set with anonymous reporting, quite a lot of subcategories in that category. Also a category around care package data and one around review data. Separately to that, ICBs are of course independent decision-making bodies in their own right, so they will have their own assurance mechanisms. NHS England and NHS Improvement, of course, have a remit to provide strategic leadership and organisational development to make sure that those local systems are operating effectively. And the national framework stipulates that NHS England and NHS Improvement hold ICBs accountable for correctly discharging their functions in respect of continuing healthcare. And I understand that tends to be done via the regions primarily. So ongoing communication, sharing learning across sub-regions, disseminating best practice and identifying trends that need to be addressed. In addition, you then have Care Quality Commission, CQC, which also now have a role to play in continuing healthcare as a result of the Health and Care Act. They should be conducting reviews and performance assessments of healthcare services delivered within an ICB footprint, and looking at the function of the system. That, as I say, that includes continuing healthcare performance now, but we're yet to find out further details as to how exactly that will work. I don't know if anybody else has more details about that. And then finally, the Ombudsman, of course, Parliamentary and Health Service Ombudsman, continue to have a role in monitoring trends in complaints that they receive, both for individual ICBs and at national level.
Thanks, Dan. And do you think for healthcare professionals delivering CHC assessments that how you monitor things is clear enough for them to be able to do that?
It's difficult to know. I'm not sort of privy to the inner workings of ICBs. I do have some concerns about how well we are collectively monitoring and utilising data from individual performance of frontline practitioners. So I think there could be some gaps there. The performance of individuals obviously contributes to the overall monitoring requirements of an ICB, but I think it's easy for those performance issues to go unaddressed if we're focused on organisation-wide statistics. We attend quite a lot of MDT assessments across the country, and we have, insight into lots of different approaches around the country, and those differences actually can be quite vast. There is some excellent practice out there. We're always a bit worried that might not be bottled, it might not be captured and disseminated in the way that it could be. I know the Strategic Improvement Programme are able to do that to a point, but conversely, we do have some concerns that performance is not always as good as it could be. Sometimes that exposes significant basic training needs. But I think, it poses the challenge of ensuring that we have good systems in place to monitor individual performance and capture that individual performance as well as at organisation level, so that we can identify weaknesses in processes and training needs.
Thanks, Dan. That's a really interesting point. I was particularly interested in the point you made around, the fact that there is some really excellent best practice, and I suppose there's a challenge there for all of us how we share that best practice and make sure that it's utilised across the country. Paul, How is chat and AIMS, and forgive me, you'll have to explain the acronym there. How is AIMS reporting being impacted with the move to ICBs from your perspective?
Well, everybody loves an acronym, don't they, in the health service? So AIMS is basically a quarterly reporting mechanism. So previously, CCGs and STPs would be reporting quarterly on things like the 28-day assessments and the long waits over 12 weeks. So from our perspective as a solution provider in this space, we are looking to realign our systems to the new structures. So there's a lot of work going on behind the scenes, really to enable reporting to reflect things as they are at the moment, because it is a moving picture. Not every ICB has thoroughly integrated CCG, what used to be the CCGs, what we're now calling sub-locations, within their footprint. So there are challenges there with sort of transitional and consolidation going on, transitional things happening. But for now, reporting can be at multiple levels. So we've realigned the system to allow sub-locations to report as well as ICBs, but we're aware that that will change going forwards, and eventually the ICB will be reporting. So there are still requests for the old sub-locations to complete information, and then the ICBs in due course, I believe, will take on more of a role of monitoring the performance of their own sub-locations and then being the reporting entity into NHS England going forwards.
Thank you, Paul. So moving on then, Dan, a question on the shape of NHS Continuing Healthcare. I appreciate that you aren't directly involved in that, but I'd be really interested in your view on what the shape is today and really, where we would like it to be in the future.
Yeah, okay. Well, look, there's a huge amount of change happening all at once, isn't there? We've got the transfer of statutory responsibilities from CCGs to ICBs, continued merging of CHC teams, rewriting local policies, the new national framework, lots of workforce disruption, which can really sap resources, and it brings particular challenges around recruitment and retention of frontline staff. And inevitably, this is all going to have an impact on day-to-day business for a period of time, particularly in relation to communication channels, timescales for non-critical work, such as retrospective backlogs. So I think we need to recognise all of that. But having said that, there are some particular performance trends that we're noticing that I think we should be mindful of. Communication, it's a massive issue at the moment. We're seeing lots of complaints from people struggling to identify their CHC department or contact the appropriate team. And there appears to be quite a bit of inconsistency when it comes to contact details of CHC teams on websites. And that will be a source of frustration for people who are waiting for an assessment or an appeal. But there's a potential safeguarding risk for individuals with a personal health budget for whom they're trying to get hold of the CHC team for support. Issues with assessment. So I've talked a bit about variability. There is a lot of variability currently. We've seen, as I mentioned earlier, we've seen some really excellent CHC assessment processes unfold, detailed, thorough, fully person-centered assessment processes. And of course, the move to virtual assessments, although it has had some drawbacks, it has provided a fantastic opportunity to improve the quality of assessments, because it's now much easier to involve a properly constituted multidisciplinary team of knowledgeable professionals, which of course is the expectation of the framework. We've seen pain specialists and mental health specialists and neuro specialists and SALT, physio, all attending MDT assessments for short periods to talk about particular domains. It makes the world of difference in quality. Conversely, though, we've then seen some quite poor practice in some areas. So things like the trusted assessment model being used incorrectly, being used as a trusted assessor model without proper MDTs in place, and questioning the lawfulness of that sort of practice. This month alone, we've seen 5 completed decision support tools which have other people's care needs discussed in them. And I don't just mean, wrong names and wrong dates of birth, but whole chunks of another person's assessment clearly copied and pasted into the wrong DST, needs that don't bear any resemblance to the person being assessed. So 5 in 1 month. And that totally destroys any trust that the individual might have in the ICB's competence to carry out accurate and fair assessments. So I think the interesting thing for me, from an audit and governance perspective, is how those DSTs manage to get through verification. So there's a challenge there about verification and governance. We've got huge numbers of people complaining to us that they can't get checklists completed, so access to the start of the assessment process appears to be a challenge in some areas. Do we have appropriate systems in place to ensure the right cohort of trained health and social care professionals are equipped to carry out checklists? There are then commissioning issues. This is particularly in relation to personal health budgets. Those are on the increase. We know this is a particular area of concern for the Ombudsman. They're watching closely following an increase in complaints. 95% of the commissioning issues that come our way around domiciliary care challenges, we find that there's no support plan in place, and there hasn't been a support planning meeting. So again, what systems are in place to ensure that PHBs are followed up with a proper support planning process? And then finally, just related to that point, I'll just say something very briefly about top-ups. It's another area in which we know the Ombudsman have taken quite a firm line on recently, but we're continuing to see them. And we're not just talking about top-ups in continuing healthcare that have been deliberately put in place by the ICB or CCG, but where they've been allowed to develop because of a lack of contractual oversight of providers. So are we ensuring that we have robust contractual and procurement systems in place to make sure that, providers are not making requests for third-party top-ups directly of individuals? There's one case in particular in which there was no support plan process carried out, and the individual incurred up to nearly £250,000 worth of care fees, which the CCG was then liable for. So I do think that ICBs could be carrying some significant financial risks if top-ups are allowed to develop unchecked.
Thank you, Dan. Paul, we mentioned that that there's clearly some workforce challenges that impact on CHC delivery and governance. How can audit tools support some of the workforce challenges that the ICBs are facing?
Well, I refer back to chat again, because chat has an awful lot of content related to the preparedness of the ICB to deliver CHC services, and that includes obviously the capability of the workforce. I'll just quote one of the key lines of inquiry in chat, which is the E2, which says specifically about the capacity and capability of the ICB to deliver the CHC service, and highlight shortfalls really to their own boards, but also to NHS England where there are recruitment issues. So an honest self-assessment using something like chat will be a way of really showing to yourselves that there is an issue with workforce, and obviously then that becomes a more sort of systemic view. Once those chat reports are made regionally and nationally, you'll be able to see from the evidence being put forward by the local systems where the challenges are. Now, I'm not an expert in delivering CHC services, I'm a sort of technology guy, but from the outside looking in, there are obvious sort of challenges in terms of workforce recruitment right now, and doing audits of the available staff, the levels of their training, their suitability for their roles. Tools are available that will help record all of that, and there's certainly sort of data and analytics tools where you can compare current data with historical data. So are your staffing levels comparable to where they were? What is the workload in relation to the number of assessments that need to take place, and do we have sufficient staff? And what are our recruitment policies? Are they being effective? Again, these are all areas in enabling the CHC service, which can be covered in the chat tool with sort of best practice guidance. But it'll be interesting, maybe the audience here today would have their own views in terms of what does and doesn't work, but certainly highlighting it and using audit tools to really be more analytical about it, and what I'd call being insight driven. What is the actual data telling us, is a way of sort of then upping the ante and raising those issues with those who need to know, who can then help hopefully with the resolutions to those issues around workforce.
Thanks, Paul. Do you think that chat is used? Can you hear me actually? Oh, you can. Brilliant. Okay. Is chat used as a dynamic tool, or you sort of almost on a daily basis?
I wouldn't say that. It's supposed to be something that gives a higher level view. So if you think, you know, from above looking down, what is happening across all aspects of my CHC service, and you know, you'll be too busy, hopefully, with operational issues to be sort of constantly in and out of chat on a daily basis. But it does have the flexibility to respond to things in a more sort of timely fashion. So if you spot something in chat, you think, well, that's an obvious deficiency, you can rate it red. There's the RAG rating system to highlight where the issue is. And then you can set action plans for the appropriate staff within the service to try and do something about it. And that can be, you know, any time frame from a week to a month, whatever. But yeah, I think it can be dynamic, but I wouldn't quite characterize it as a daily system. It's more that sort of umbrella quality assurance view from on high that enables you to sort of self-assess your strengths and weaknesses.
Thank you. So Paul, again, I mean, Steve Farley's asked an interesting question on monitoring performance, and I think he's talking about trends and you know, can it support measuring, you know, trends in eligibility, for example?
Well, that's not something that the chat tool itself would measure, but I would imagine it's something that you know, your care track, your broad care type systems would be reporting on, and that NHS England, I guess, would need to know. So, but I suppose like with anything like that, where there are trends that need analysis, you look at the factors beneath those trends to say, you know, why are those things happening, and you know, is there a difference in trends between high performing services and lower performing ones? And so, you know, I'm not an expert in that particular area in eligibility, and our systems, as I say, don't actually capture that data, but it's another factor when looking at the health, I guess, of a CHC service.
Yeah. Thanks, Paul. Dan, do you see the benefits in monitoring trends, and how do you see, you know, are we good at doing that? Could we do better?
I absolutely see the benefit, and my one concern, well, one of my concerns actually, is that we might be losing some of the more kind of nuanced data that we would have normally reported from CCGs on a monthly or quarterly basis. So if those data monitoring and reporting requirements move to ICS system level, then I worry that we're going to lose quite a lot of the sort of nuanced detail that we used to have from the old CCG data, because that data is really quite useful, helping us to kind of benchmark eligibility rates from area to area and sub-region to sub-region. So yeah, I think that's important to be doing at national level. Well, it's something that is done at national level, but as I say, I'm a bit worried about losing the nuance. But it's something that we can be doing at, and should be doing, I think, at local level, and that can be done really to a degree of minutiae in you know, capturing and analysing trends in MDT recommendations according to MDT members, panel decisions, the number of assessments that have to go back to the MDT for further work, combinations of, you know, eligibility decisions depending on verification panel makeup. There's all sorts of audit we can be doing to analyse trends and performance.
Thank you, Dan. So if I move on, so we talk a little bit more about audit tools and how they support the drive for best practice. Paul, can you talk us through how the chat tool can help drive best practice?
Yes, I mean, it's about doing continual self-assessment of your strengths and weaknesses, really. And the chat tool, I was there involved in many meetings when, you know, the standards were defined, and using content from things like the National Operating Model, from the Maturity Matrix. It really is a very comprehensive end-to-end audit tool for a CHC service to really ascertain right from the start, through assessment all the way through to service delivery, through all the building blocks, through their systems. Do they have a digital end-to-end process? And it's about sort of identifying those strengths and weaknesses, alerting yourselves and the people who need to resolve the issues, and then actually acting upon them. Because obviously, if you don't act upon the things that you find as shortfalls, then that improvement doesn't happen. So the system is designed to help you there. And then there is the peer review. So the NHS regional teams, NHS nationally, can potentially assist by looking at your evidence, involving themselves with the local teams to try and embed that improvement, and signpost the guidance that there is there. But yeah, it's a self-help tool that if the CHC services take seriously, I'm convinced will help them understand exactly where they are on the journey to where they need to be, and shares that information with the NHS England teams so that they can actually assist in that process. We've also started developing a tool that sits beneath chat, which we're going to call ACT, which will also assist in that sort of transitional development. So there will be things that the systems need to do to change, to consolidate and to sort of embed things as a single sort of system. And as I say, there will be new tools that we're certainly working on that will help people prepare, and then will feed into chat to give that sort of wider picture. So yeah, there's a lot going on behind the scenes, and the chat tool will certainly help people indicate where they are on their journey.
Thank you, Paul. And Dan, how do we assure ourselves we undertake best practice compliance within CHC?
Well, in order to assure ourselves, we need to know what best practice compliance actually looks like. I mean, it sounds basic, it is basic, but that requires a really thorough knowledge of the national framework. That's the starting point. Proactive steps taken to shape our local systems and our local policies to the key principles in each area of the framework, each area of CHC delivery, referral, MDT assessment, decision making, planning, commissioning, larger scale procurement. We mentioned already managing provider contracts to prevent issues around unlawful top-ups from arising, for example. So making sure that those systems are absolutely robust and they are and they reflect national policy, and then making those expectations clear to frontline health and social care staff. I think only when we've understood what best practice in all those areas looks like, and then taken steps to align our systems accordingly and clearly communicated those expectations to our teams, can we then monitor the effective delivery of those systems and to identify weaknesses either in the system themselves or the operational delivery of those of those local policies. So identifying individual or team performance issues. But there are plenty, as we've been hearing about with chat and practice guidance, e-learning, NHS England's e-learning, the competency framework, the delivery model. There are plenty of tools at our disposal to help drive quality and monitor performance.
Thank you. And do you see the introduction of ICBs, so that gives you a sort of wider approach? There are potential benefits there from a sort of geographical and demographic point of view in understanding some of the challenges, but being able to utilize systems and performance more effectively to support people.
Yeah, I mean, I guess the obvious benefit is being able to when you're merging together a number of CHC systems, all of which will probably be doing things in a slightly different way, and you're trying to come up with your new policy, and that policy is going to apply to a wider geographical area. Then the obvious benefits are learning those best practice elements of each CHC team's systems and making sure that we incorporate those into the ICBs overarching policy, and using that to maybe address some of the more potentially deeply rooted cultural failings or challenges that individual CHC teams might have. Of course, there are probably other benefits around a greater commissioning power, greater procurement power, if you're procuring services across a wider area. So I think that, yeah, I think there are real opportunities there, but there are certainly some challenges as well when it comes to mixing cultures of CHC teams.
Thank you very much, Dan. So Dan, can I ask you another question on how compliance can be made front and centre for all commissioners?
Yeah, okay. So I've got a few thoughts here. I mean, first of all, continuing healthcare is a whole system issue, not just an ICB issue, despite the statutory responsibility sitting with the ICB. Governance arrangements require a response across all those statutory agencies to make it work, and across other involved partners. So whilst ICBs are responsible for system leadership within their patch, there is an opportunity to draw partners more closely into delivery and performance monitoring as part of that whole system approach. Education is really important. Education about continuing healthcare is also necessary at every level of an ICS. Senior managers and directors, boards, have they done e-learning modules considering around continuing healthcare governance, for example? You know, continuing healthcare incurs a disproportionately high spend compared to other NHS budgets, so we need to be certain that we're getting eligibility decisions right and have those effective commissioning systems in place, but balancing that with legal responsibilities to make sure that all care needs are met. And that means senior leaders need to be educated to understand what continuing healthcare is and the importance of clear governance structures. And I think in the longer term, we need to be working towards education rather than training. There are lots of training providers like CHS, Beacon, we provide training as well. It'd be good to see a bit more regulation around training. NHS England obviously does quite a bit of training, but I think we really need to be looking at education, courses, qualifications. Staffing is another area. We need a strategic approach to training and developing and recruiting staff, ensuring that local policies are fully compliant at national level. But more than that, we're putting steps in place to attempt to incorporate best practice as well. You know, CHC assessing can be a hugely demanding job, and staff can really be set up to fail sometimes. We've seen that. Our own experience shows that, you know, if staff receive inconsistent messages or incorrect training, that can really set them up to fail, and it has a significant impact on morale. So it really emphasises the need to get back to the framework, to be intentional about aligning our systems, and then putting structured training and development plans in place for practitioners using the tools that we've already talked about. And we've got some, you know, robust, making sure there's some robust systems in place for performance monitoring, as Paul's been talking about. If we align the expectations of the framework and best practice to those key lines of inquiry, then those systems you know, should then prompt. Well, it will be more likely that those kind of best practice elements of the national framework will become ingrained into the culture of our assessment processes. So having clear systems in place are really important. I'd also just say something about spot audits of DSTs and decision making. I think that's really important. That will help to pick up on areas of misunderstanding within the teams around, you know, for example, around domain descriptors, and also inconsistencies within teams. Sharing case studies or even formal peer review audit of a selection of decision support tools across CHC teams within an ICS footprint, that will help to drive up quality and to share best practice. And we'd also really strongly advocate independent audit. We've carried out some independent audit of information materials. We've done CCG panel decision-making audits as well. I know other organisations do that as well. But whole CHC systems can be independently audited. But I think if you're going to do that, I'd recommend jointly commissioning the provider with local authority, that's going to promote interagency confidence and reduce disputes. And then complaint handling, I think we're often afraid of complaints, and we see quite a lot of variation in the way that complaints are dealt with, but we need to embrace them because it's one of the best ways to identify challenges in our processes which need addressing for the good of the people that we're serving. And that requires a willingness to accept constructive criticism and a positive attitude to putting things right. And I think, you know, patient feedback every time is an important strategy to help identify trends as well. So I'll leave it there. I'm sure there are plenty of other ideas.
Thank you, Dan. No, that's really helpful. And Paul, how do you see the role of CQC developing in terms of monitoring ICB compliance?
Well, that's a very interesting question. And how does CQC see themselves in that role will be another question to ask. So the ambition is to create a consistent assessment framework across the whole system. So, you know, from an ICB all the way down to, you know, a domiciliary care agency, a set of what the CQC are calling quality statements will apply. So you have a set of goals that says, as a provider of services, these are the things that we would do. So we will have a learning culture, we will have training, we will treat people with dignity and respect, we will do safeguarding. So how that quite works at a whole system approach compared with, you know, somebody actually delivering, you know, frontline health services, I'm not entirely sure, but that is certainly the aspiration. What we haven't seen is sector specific guidance for all those different echelons from CQC. So they've been trumpeting these new assessment frameworks, they've been trumpeting, you know, what the question should be, but then they haven't been so forthcoming with the how-to bits. So what does that actually look like for an ICB? What exactly are we going to be rating them on? So they have what they call evidence categories, and really to further one of Dan's points, the importance of feedback will be very important. That will be feedback in the terms of, you know, what surveys and those sorts of things are saying, but also from other agencies that they work with. They're trying to get that rounded picture. It's not just the self-assessment, it's not just the evidence, but it's about, you know, what the data is telling you. That phrase being insight driven, to have the information at your fingertips, the numbers that reflect the actual performance rather than, you know, the ambition and the sort of generalizations. So I think they're going to be a bit more clinical in their rating systems, and they're actually going to put scoring mechanisms against the data and the all of the evidence that they find to try and rate people in their rating system. You know, are you outstanding, good, requires improvement, or inadequate? So there's going to be quite a lot of involvement from CQC in terms of gathering that information, but from the outside looking in, I don't necessarily see that the teams have necessarily been formed that are going to carry out that function within CQC. I haven't sort of seen any evidence of that, and whether they will just move people from sort of clinical settings to a new role in trying to assess what's happening across an ICB. I'm not sure how that works. There's also been anecdotally some evidence that some of the changes in CQC and some of these new things that they have to do haven't necessarily been sold to their workforce. So there is some discontent, I think, within CQC. I've seen reports of the unions getting involved and demanding meetings with CQC and things like that because people haven't been consulted in their changes, and even, you know, sort of being re-interviewed for their own jobs under a new regime in the, you know, in the new setting. So yeah, let's watch this space. I think CQC needs to be a lot more forthcoming in what's happening. It would certainly help us across all levels, not just at sort of ICB and CHC, to understand more of what their thoughts are and what good looks like. You know, what are the targets that people will need to aim at? What will be the source of evidence? Because it just really isn't available. Well, if it is, it's not apparent as to where it is at the moment.
Thank you, Paul. No, that's really helpful. And we've been asked one other question, and another acronym for you. Is ACT being developed with NHSE?
So the ACT tool that I referred to earlier, which will be another acronym, as you say, the All Age Continuing Care Transformation tool, is really designed to assist people taking those steps to become a sort of fully functioning, consolidated, single ICB service. We're not actually developing it with NHS England. We're using some other partners to help us with that. But the idea is that we will be offering it to ICBs going forwards, and obviously we will be sharing with NHS England because it's an important part, and we obviously value their views in the tool that we've developed. But we certainly hope that it's fit for purpose, and we've had a lot of expert input into designing the tool.
Thank you, Paul. So we haven't had any other questions from anyone attending the webinar. So Dan, are there any other points you wanted to make before we head to a close?
No, I think really just to emphasise the importance of starting with the basics and making sure that we have a really good, clear understanding of our the key principles of the framework and our responsibilities under the framework, and then we align our systems accordingly, and then disseminate that to staff. We have been concerned for some time that there about I guess kind of lack of assurance until latter stages of appeal and complaint processes, and we're hoping that CQC's involvement might help to resolve some of those issues earlier and gives ICBs the confidence they need to address anything that needs addressing. But obviously, as Paul's mentioned, there are some potential teething issues there. But I think these are challenging times, these are demanding times, and it's going to take a little while for systems to settle down and business to return to normal. But I think framework talks a lot about the importance of the person-centred approach. I'll end on that because person-centred approach is so important. Transparency and communication are really at the heart of this principle. Poor communication really frustrates, and nothing creates the perception of unfairness like a lack of transparency. So if people feel that processes haven't been transparent or inclusive, and with really good communication at all levels, it creates deep suspicion, and that can push people into complaint and appeal, even if they're miles away from eligibility. And those complaints and appeals, they're costly and they sap resources. All of that starts with good governance, compliance systems, good communication, and audit systems in place to monitor performance.
Thanks, Dan. And Paul, is there anything else you wanted to add?
Well, as a technology provider, I'll just sort of put the offer out there that if anybody's interested in discussing how sort of technology can help auditing, how you can automate the process, how you can collate all the results, how analytics can then help you display and do trend analysis on the results of audits that you might be carrying out. And we have all sorts of tools available. Chat itself as an audit tool, obviously I would commend to ICBs and their sublocations as the obvious way right now to benchmark your service on your journey, to become a fully functioning and good or outstanding service. But we'll see what CQC come up with that maybe will help in that process. As I say, we're waiting for more information from them as to what their expectations will be. But yes, from a technology point of view, if there's anything we can do to help people, my door's always open, and we'd be very happy to have further discussions with people.
Thank you, Paul. So if I can bring things to a close, I think this has been a really useful discussion, and thank you, Paul and Dan, for freeing up your time and sharing your experience and expertise with us all today. Clearly, CHS, CHC compliance audit, it's a complex area, and there are challenges as the ICBs form we clearly know there are issues around workforce recruitment, workforce development. So, what is clear for me from what we've discussed today is the importance that we do monitor and manage performance across all aspects of CHC operations as effectively as possible. And in order to do that and to comply with the national framework, we need robust processes and appropriate resourcing in place to do that, so that we can look to deliver consistent ongoing improvement and quality across CHC across the country. Clearly there are issues around how we collect and monitor performance. I think we heard from Dan that there are some really outstanding areas of best practice, but also some areas where things are perhaps not as good as they should be. So, as I said, potentially there is a challenge there for how we ensure that best practice and compliance with the national framework is in place. We heard from Paul and from Dan around the importance of utilising a range of tools that are available to help support audit and to monitor performance. So as I said, I hope that was a useful session for everyone. Clearly, if anyone does have any further questions, I'm sure that, as Paul said, he's very happy to discuss anything with anyone who wants to hear about the services and the audit tools that Paul provides. And I know that Dan is closely linked in with a lot of people who are on this call as well. If we can be any help, as I said at the beginning, we provide a range of services, including audit support. We're happy to talk to anyone about that as well. So I'm going to bring this session to a close. As I said, thank you very much for attending. Thank you to Paul and Dan. We look forward to hosting you at our next webinar. If anyone has any specific topics that they would like us to cover, please drop us a line at olivia.roden@chshealthcare.co.uk, and we'll be happy to host that and to facilitate that accordingly. So wish you a very good Friday and enjoy your weekend, and thank you very much for being with us today.